might know her. Dr. Yuzi, she had a postgraduate study from University Malaya for master in obstetric and gynecology. She served as a doctor in Malacca before. She was an ex head of department from Hospital Tawau in Sabah before, and currently she's worked in Johor Hospital of Pina. And she's a maternal fetal specialist in Johor. Like to welcome her, and will be not by handphone because I have a lot of comment regarding during Dr. Michael presentation. Some of the smaller screen then I think some of the slide might cannot computer based. We can see a much more clearer picture. In future, we try to enlarge our PowerPoint. Hopefully, can enlarge more bigger size so everyone can see those are using handphone or smaller screen lah. All right, and please post all the question in the chat. Please mute all your microphone. Please mute all your microphone so that presenter can present without any disturbance. And please sign in your attendance. All right. Okay, Dr. Izzy, are you ready?
Yes, Chan. Thank you so much for inviting me to this webinar. For the record, I'm no longer serving in Hospital Tanah Mina. I'm back at my hometown in Melaka. I just finished my MFM in Hospital Tanah Mina. So bye JB. Okay, without further ado, I will start regarding in continuation of the basic ultrasound. Dr. Michael already talked about how to do a basic bioparameter of the fetus. So we continue the placenta evaluation and also the amniotic fluid evaluation. You guys can hear me loud and clear, right?
Yes, Dr. Yuzi. Loud and clear.
Go ahead.
Yeah.
Okay, so we'll start from for the placenta first. So as we know, the placenta comes from the Greek names, which means flat cake. Placenta is responsible for the fetal nutrition, respiratory, and also excretory of the functions of the fetus. And with the detailed systemic assessment of the placenta, we can have a standard imaging during the
recording in progress.
So with the help of color and power Doppler, we also permit the direct visualization of the placenta vascularity, which assess in both uteroplacenta and also fetal placenta circulation, which may help in terms of fetal monitoring, besides Dr. Michael as mentioned before, using the growth chart. So what is the placenta? If you know, the placenta have two components. It's a fetal maternal organ and have two parts. The fetal parts, which is your chorion sac, and also the fetal. This is the function of the placenta, as you all know, for the protection, for the nutrition, respiration, excretion, and some hormone production. So in gross section, you can see this is quite familiar to all of you. This is the placental size and this is the maternal size. The maternal size, you can see all the cotyledons, which is irregular and divided into convex area. And as you can see, the fetal side is basically the chorion amnion. It can seen as smooth, transparent, with the umbilical cord attached as near to the center, and also the three vessels of the umbilical cord. So this is gross specimen. So what do you expect to see in ultrasound? So for the fetal side, you only can see the membrane. So this is the chorion amniotic membrane. It's a thin line, hyperechogenic, which you can appreciate in your ultrasound. And towards the maternal side, you can only see the cotyledon, which appears as homogeneous ecotexture. Okay, it's black, either black in color. It's not black in color. It's in between. And also, you need to appreciate the retroplacental space, which is between the myometrium and the placenta. This is what we call a retroplacental space hyperechoic. Why you need to appreciate this, I will tell you later. So as we know that the placenta develop towards end of the 3 trimester. So in the first trimester, what do you expect to see in ultrasound? Is basically just focal thickening, and it's just at the periphery of the gestational sac. Okay, you cannot see the placental bulk as a whole. But towards the 12 week and 14 weeks, you can finally appreciate the fine granular and homogeneous and smooth chorion. Okay, smooth chorion covering the fetus. And as you can see, as you know, as the placentals grew after 14 weeks, it will appear as heterogeneous or homogeneous with some focal echolucency. Some towards the end of third trimester, you can see some venous leaks. And bear in mind, you need to know the size of the placenta because it does matter towards the third trimester, whereby it covers 1/quarter of the myometrium towards the 20 weeks of pregnancy. And by the end of 38 weeks, it covers just 1/10 of the uterine cavity. So before I move on to how to appreciate the placenta and appreciate the abnormality that we can see in the placenta, I think Michael and Chow also have this referral a lot, whereby they refer it as either diminished twin or some retroplacental clot at early gestation. This is what we call a chorioamniotic separation. I didn't expect you as a frontliner in the klinik kesihatan to diagnose this, but it's a good thing to know that you can appreciate this chorioamniotic separation. As we know that placenta membrane, the chorion and also the fetal membrane remain separated until 14 weeks. Then after 14 weeks, these two lines will fuse together. And after 40 weeks, you will not able to see this line anymore. So it's a rare spontaneous event which occurs about 1 in 3,000 live birth. And most of the time, if you can see this chorioamniotic separation after 14 weeks, is associated as associated with fetal malformation or some aneuploidy. And following some invasive intrauterine procedures such as amniocentesis or fetoscopy or open fetus surgery, you can actually have this kind of complication, and bear in mind that they can cause some consequences to the baby, such as amniotic band sequence, whereby you during the ultrasound you can see some fetal limbs or body part being amputated or some defect. Or even worse, there are some risk of ruptured the membrane. So these are some pictures showing some to show you for you to appreciate the chorion amniotic separation. This is about 8 weeks, and you can see this. Okay, this is the yolk side. All right. Okay. So when you see this, sometimes some people may mistaken this as an embryonic blighted ovum. So it's okay for you to see this and refer to us to the tertiary hospital, because you in klinik kesihatan, some of the machines I know is very old. So sometimes you cannot really appreciate the small embryo. And so as I mentioned before, why we need to appreciate this chorioamniotic separation after 40 weeks, because they can cause amniotic band sequence. This is some example that we can appreciate in ultrasound. This is the fetal limbs, whereby this some constriction due to the amniotic band, and this is the gross picture. Okay, and this is the fetoscope showing that some amniotic bands constricting the limbs. So when you want to evaluate a placenta with the ultrasound, these are the things that you at least do a checklist for you to see, for you not to miss anything abnormal in the placenta. Because basically, a basic ultrasound is for you to see the normal one, and then identify what is abnormal. So the first thing you need to know, where is the location of the placenta at the uterine wall, whether it's the anterior or posterior, or sometimes it may extending to the lateral wall. The second thing you need to know, this is important because this is the one that you always miss, because sometimes you have upper segment placenta, but referred to us as low-lying placenta, the site of the placenta, which is you need to determine after 28 weeks. The echogenicity of the placenta, why is it important? I will tell you later. The variant of placenta morphology for klinik kesihatan maybe is not as relevant to those working in district in hospital with PACA, because there are some complications associated with the variant of the placenta morphology. It's good to know the cord incision, because placenta is just not only placenta, but you also have cord. So I will talk a bit about the cord insertion. And last but not least, the pathology. We'll go through some pathology of the placenta that you may pick up during your routine basic ultrasound. So these are the things that you can appreciate the placenta size. You can have hyperplacentiosis. You have placenta and abnormal cord insertion, morbidly adherent placenta, bleeding in the placenta or around the placenta, and also tumors. Some tumors, which is commonly what you can see is a trophoblastic tissue. So first of all, please ensure that you place your probe properly. Okay, make sure your arrow is always pointing towards your superior arrow must be pointing towards the mother xiphisternum. So first you place the probe longitudinal on the lower abdomen with the superior pointing towards the symphysis pubis, and you do your first swipe to locate the fetus, whether the fetus is in the longitudinal line or in the transverse line or oblique line. And after you do the longitudinal, your superior swab, you do your swipe at the side to ensure where is your placenta localization. So please know your orientation between your probe and your ultrasound image. Otherwise, you'll be confused later. So the placenta location determined according to the main placenta body, which is the major member from the uterine equator, meaning that from the center of the uterus. It can be anterior, okay, it can be posterior, it can be in the fundus, or it can be the low-lying. So this is the image that you can appreciate. This is anterior, this is superior to, this is near to the probe, this is away to the probe. This is superior, which is towards the maternal xiphisternum, your uterine fundus, and this is near to the internal os, near to just below the bladder. So anterior, posterior, superior, inferior. So you have to know this for you to make the diagnosis of placenta previa. Otherwise, you mixed up. So to determine the site of placenta, for you to tell this is a placenta previa or not, or low-lying placenta, you can use two approaches, whether the transabdominal approach or the transvaginal approach. Bear in mind, when you are using the transabdominal approach, which most of you will do, you have to make sure the bladder of the patient must be full. Otherwise, you will have very lousy image and you cannot determine the localization of placenta, the site of placenta, especially those in posterior placenta. And make sure the image must be in the mid-sagittal section, okay? And to determine whether this is upper or low-lying placenta, you need to determine where is your internal os. Then you measure the lower edge of the placenta from the internal os. So as I mentioned before, for you to have a good view or good image of the when you are doing a transabdominal approach, you must have the bladder full, and you will visualize this. Okay, this is cervical canal, this is cervix, and this is your internal os, this is your external os. So for you to have this good image, you must have this, because apart from your the bladder will push the presenting part up above, and you will have this fluid become your medium to for you to visualize this. So this is your internal os. Again, this is your external os. So you need to measure, you need to identify your internal os and measure the lower edge of the placenta. As you can see here, this is the lower edge of the placenta, and this is your internal os. So you do the measurement. So I know that clinic kesihatan, you don't have any transvaginal probe, but to the benefit of those working in the district hospital or hospital with the SPACA, we can do a transvaginal approach by putting a transvaginal probe into the vagina and do your measurement and identify the site of the placenta. But bear in mind, you have to do it gentle, otherwise. So what you can do is you take your transvaginal transducer, you put it inside the vagina, which is away about 2 cm from the anterior lip of the cervix. Forget about the angle. Sometimes in the vagina, you can have retroverted and anteverted uterus. So just put the probe anterior to the cervix, not onto the cervix. Otherwise, you will have you won't see the internal os clearly. And make sure before you do all this, in contrast with the transabdominal approach, you must make sure the bladder, the maternal bladder must empty. Otherwise, you have a urine coming out, pouring out to you. So that's about the site and the placenta localization. What about the echogenicity? Why I stress on this? Because you need to ensure and you need to differentiate between the retroplacental cord and the normal placenta echogenicity. So in normal placenta is uniform echogenic or intermediate echogenic with deep hypoechoic band between the myometrium and the bacilla. This is what I called the retroplacental space. So you need to appreciate this. All right. Okay. This is the normal hypoechogenic or homogeneous placental bulb. So just to share with you some variant of the placental morphology, you can have saturate lobe, you can have bilobe placenta, you can have circumvallate placenta, you can have placenta membranica. These all placenta, sometimes we also can miss the shape and also the variant of the morphology. So it's just to share with you the knowledge that you can have different kind of placenta. And I just want to emphasize the saturate and also the circumvallate, because in saturate lobe, you can have placenta vasa is highly associated with vasa previa, and also the circumvallate can also associated with placenta abruptio. So this is what we can see in gross specimen, the saturate lobe, whereby you can see the two placental lobe with placenta cord insertion at the edge of the placenta, whereby the circumvallate lobe basically is just a race of the placenta as a linear band. Okay, this is your main bulb, and it's just like macam echo at the end of the placenta. So we finish about the placenta. I'm sure you all know, and your master in doing all this identification of the placenta site and localization, sometimes you forget about the umbilical cord. I would like to share with you some normal thing that you need to appreciate when you do the placenta localization and also the umbilical cord. First and foremost, you need to make sure that the numbers of the vessels is correct. You have 2 arteries and 1 vein, the cord placental insertion site, the fetal umbilical cord insertion. Sometimes you may appreciate the cord cyst and the usage of color Doppler of the umbilical cord for fetal surveillance. So this is what we always teach in the medical school, or at least the housemanship. Okay, you must have this sign, this Mickey Mouse sign, that your 2 artery and 1 vein. You have to see the free loop, the sagittal view, and you have to see the cross section of this and make sure there are 2 arteries and 1 vein. This is an example of this umbilical cord only have 1 vein and 1 artery. So another view for those in hospital with PACA, you can actually see the numbers of the umbilical cord vessels by doing a coronal view at the incision level of the fetal bladder. Okay, so you can see on your color Doppler, and you can see the side, the 2 umbilical artery is at the side of the fetal bladder, and you can appreciate here once you on the color Doppler, there's only 1 single umbilical artery running at the side of the fetal bladder. Why is it important for you to identify this single umbilical artery? Because it's very rare. It's very rare. It's only 0.6% in live births. However, as you can see, there are 34% association with fetal growth restriction, and 30% of the fetus with single umbilical artery is associated with aneuploidy and some congenital malformation, such as your tracheoesophageal fistula, your renal agenesis, your ventral perforated anus, and also aneuploidy. And also, when you see this single umbilical artery, there is some increased risk in women with diabetes, epilepsy, preeclampsia, and also antepartum hemorrhage. So it is important for you at least make sure that the umbilical cord have 2 artery and 1 vein. Just identify the Mickey Mouse sign and you will be okay. So these are some examples of what we need to look for when we are looking when you have a single uterine artery. For clinic kesihatan, it's good enough for you to just mention there's 2 arteries and 1 vein. You don't have to see all this, because this is only the maternal fetal medicine specialist can appreciate and do all this fetal anomaly scan. So what to do when you suspect when you see a single umbilical artery? Okay, for you, we have to refer in clinic. For those in clinic kesihatan, you have to refer for a detailed anomaly scan, and we can proceed with fetal echocardiography, and some we can offer amniocentesis for genetic testing. And we have to, because as I mentioned earlier, is 30% risk of fetal growth restriction. So you need to make sure you do the fetal surveillance and serial fetal biometry with plus minus Doppler study, your umbilical artery Doppler. And also the prognosis of this kind of fetus depends on what kind of associated anomalies that we found in this baby. And after the baby was born, you need to refer the baby to the neonates clinic for physical evaluation, especially to do the renal sonography. And also the recurrent risk of single umbilical artery depends on what anomaly that you found at that particular baby. So move on to your placenta. This is very interesting because you only see the placenta, but you forget about the cord. Why is it important? Because not much of the towards the placenta incision, because if you are not trained to do this, you may miss the site of the cord incision paracentral. However, okay, this is just example where you can find actually the cord insertion towards the placenta. However, you shouldn't miss this. Sorry. Okay. Just a little bit about this abnormal cord placenta site insertion. The velamentous cord insertion, the marginal insertion, or the vasa previa. This is important for you guys to practice in clinic, in the district hospital or in hospital with pakar. Okay, just these are a few things that you need to know, because even though the velamentous cord insertion is very rare, it's only about 1%. However, is increased risk of getting a vasa previa in this kind of patient. So these are some examples where you can appreciate the marginal of the cord insertion, where it's just at the edge of the placenta. Okay, you need the color Doppler for you to confirm the placenta, the cord insertion to the placenta. This is what we call a velamentous. It's just actually a cord, umbilical the fetal vessels running through the amnion. Okay. So why I stress about the importance of identifying the vessel cord insertion through the vessel, the placenta, because you can have this very devastating condition which can lead a high mortality, which is about 80 to 100% if you miss this. Okay, what we call the vasa previa is actually unprotected fetal vessels through the fetal membrane, crossing and running through near the os just beneath the cervix. Okay, if you can appreciate this, the fetal vessels and also fetal vessels. Okay, so if you have this, you have torn the vessels and ruptured the membrane by a spontaneous rupture or doing artificial ruptured membrane, is a life-threatening, and you can lose the baby in split second. Okay. So you have, as you know, the vasa previa have two types, the type 1 and type 2. Type 1, you have a velamentous cord insertion, okay, whereby the fetal vessels running freely within the amniotic membrane overlying the cervix. And type 2, basically your saturate lobe, and the two vessels connecting the two lobes and overlying the cervix or os. So 3 steps for you, especially those in a hospital setting, for you to at least screen for vasa previa. First of all, you need to appreciate the cord insertion into the placenta. Where is the cord insert placenta lobe? So basically you are doing a placenta mapping to make sure you exclude the bilobe or sensory lobe, and evaluate the lower uterine segment. Evaluate this and put on your color Doppler to make sure there's no cord overlying the cervix. So clues in ultrasound. First, there's a linear sonolucent across the placenta or near to the placenta. And when you on the color Doppler, you can see this color uptake at your suspicious area. And most of the time, the color Doppler sonography will show the vascular structure. Okay, it's hollow structure overlying the internal os. However, you may sometimes mistaken with the free flow or free loop or free loops of the umbilical cord, where you can actually differentiate by asking the mother to move left to right, and this will, if this is a free loop, it will move away from your internal os. Okay, so what we call it a Fulnick presentation, which all of you known as cord presentation, which can be commonly confused with a vasa previa. Okay, this is something that we not commonly done in patient at third trimester, but it's good to know it's a good practice for you to do this and appreciate any vasa previa or any cord presentation. So make sure if you're in the hospital setting with pakar, make a habit, especially those in master student, make a habit for you to detect this vasa previa. So this is the one that I would like to emphasize to the clinic kesihatan, because I got a lot of referral from clinic kesihatan. I got a lot of referral from my dear MOs saying that the clinic kesihatan missed this, the amphilocyl. So you know that physiological herniation of the abdominal content in the base of the umbilical cord is normally seen in the first trimester, especially less than 14 weeks. But however, this is what you should see after 14 weeks, whereby the mid-gut herniation and return to the abdomen had occurred after 40 weeks. So you should only see the umbilical cord, not the whole abdominal content at the level of the cord insertion to the fetus. So in order failure to do that, failure of the mid-gut herniation, you can appreciate this amphilocyl. This is what we can see in the ultrasound, whereby you, at the level of the abdominal circumference, you move your probe, move down to near to the bladder, and you can appreciate this, what we call umbilical cord insertion to the fetus. And if you don't see these 2-3 vessels running through and you have extra loops, then you have to think whether you are dealing with amphilocyl or not. This picture shows the whole liver lobe is outside the abdominal cavity, and you can see this amniotic membrane covering the abdominal content. This is as early as 14 weeks, whereby you can appreciate this is actually a cystic hygroma, and this is the amphilocyl. And as we know, amphilocyl is associated with more than 50% of your aneuploidy, especially the trisomies. So it's just a quick view, because I think Dr. Chan will talk more about the usage of color Doppler for the fetus surveillance. Basically, the ISO recommendation, International Society of Ultrasound recommend how to do the Doppler ultrasound for the umbilical artery by using the free loop cord. Visualize the free loop cord, not too close to the fetal cord insertion or any placenta insertion. And you make sure you zoom and magnify the area of the cord. You're on the color Doppler to make sure this is the umbilical cord that you see with the color uptake. And then you put your caliper and start your pulse width Doppler function. So basically, this is a normal characteristic of sawtooth appearance in the arterial flow that you need to see when you do a color Doppler for the umbilical cord artery. This will elaborate, I think Dr. Chan will elaborate more on the Doppler in the next session. So just to share with you some abnormality that you can appreciate in the umbilical artery waveform. This is normal, as you can see, systolic, diastolic. And this is absent end-diastolic flow, whereby you cannot see, comparing to this, you cannot see the end-diastolic flow. This is reverse, where you can see the diastolic flow at the other side, this reverse. Okay, sometimes when you do, you can have this interference. This is what we call a breathing interference from the fetus, which is normal actually. So we already finished what is normal to see in the placenta and also in the umbilical cord. So now we are going to go through a few few placenta pathology that you can see in the placenta where you do the placenta evaluation. So this is the thing that you always refer to as placenta previa. As you know, placenta previa is abnormal implantation of the placenta in the lower uterine segment, whether it's overlying or near to the internal os. So you should measure, as I mentioned before, for you to see to ensure the placental site, you must make sure you see the internal os, appreciate the internal os, and you measure the lower edge of the placenta from the internal os. And the measurement should be more than 2 cm, otherwise you consider this is a low-lying placenta. And as you know, the relationship between the placenta and the internal os change throughout the course of pregnancy as your baby grows and the placenta, as the uterus enlarge, and the lower segment starts to fully form after 28 weeks. So therefore, this is why you make the diagnosis of placenta previa after 28 weeks. So I don't have to go through the classification. I'm sure all of you are aware of the classification of placenta previa. Based on the current classification, we can divide into minor or major classification. Minor consists of type 1 and type 2 anterior. And the major classification, placenta previa consists of type 2 posterior, 3 and 4. So I'm sure you have diagnosed placenta or placenta previa, placenta major throughout your practice. It's just to share with you. This is placenta type 2 and this is placenta type 3 with this is your internal os. This is a placenta edge which completely close the internal os. This placenta type 2 posterior, whereby you identify this is the internal os and the placenta margin is just reaching the os. Okay, this is your placenta, this is your cervical canal, this is your internal os. Again, this is your placenta edge. So this is type 2 posterior. And this is type 4, is your major complete, whereby you can see the internal os, the cervix, and the whole placenta bulk is sitting on the internal os. So I'm sure you'll be able to diagnose placenta previa at this point of time. It's just the matter whether you're seeing the correct thing, whether your technique is correct, whether you can appreciate this internal os correctly, and whether you can appreciate this lower edge of the placenta correctly, especially those in posterior placenta. So when we talk about placenta previa, we cannot run away from morbidly adherent placenta, or now we call it a placenta accreta spectrum. So basically, it's just chorionic villi of the placenta embedded outside the myometrium, whether we can have this placenta embedded in the myometrium, what we call the placenta accreta, which occurs about 70% of the PAS. Placenta accreta, whereby the placenta embedded at the placenta accreta is whereby the placenta, the chorionic villi invaded to the endometrial lining, where increta is already invaded into the myometrium, which occurs about 50% of the cases. And if you have a percreta whereby the placenta, the chorionic villi or the placenta is already invaded outside the serosal myometrium. Okay, so we got in the serosal of the uterus, we call placenta percreta. So bear in mind, when you have a patient where you diagnose a placenta previa with cesarean delivery, these are the things that you need to see, because as we know, okay, in a primary, let's say in primary gravida, the risk of getting a placenta PAS is only about 3%. With in one previous Caesar, it's about 3%. Two previous Caesar, about 11%, and 20%. Four Caesar, about 60%, so more than half. So you have to remember that when you are dealing with placenta accreta, a placenta previa with history of cesarean delivery, these are the things that you need to see. So I just share with you, not much for the clinic kesihatan, because when you have the placenta previa, you need to refer. But those in a district hospital, the hospital with pakar, these are the things that some clues for you to see when you're suspecting a placenta accreta spectrum. The first one, you have a loss of clear zone whereby you don't have, remember what I said just now, your retroplacental hypoechoic margin. So there loss of clear zone. There's no hypoechoic plane or irregularity between the myometrium and also the placental bed. So the number two is the thinning of the myometrium. Okay, so you can trace the myometrium. Okay, and suddenly there's no more myometrium in between the bladder and also the placenta. So you have thinning of the myometrium overlying less than 1 mm. And the third one, you have some lacuna, abnormal placenta lacuna. Basically, you have multiple vascular lacuna spaces within the placenta, which we describe as Swiss cheese appearance. So when you on your color Doppler, they will have a turbulence flow within the placenta and also this lacuna. So you have bladder wall interruption. So this is where you suspect a placenta accreta or increta. So where you cannot see the smooth line of the bladder wall. So you can see the differentiate. You can differentiate between these two. Okay, you can see the smooth line of the bladder wall, but here you cannot see. Lost, it's gone already. And the next thing you can see, you can appreciate the placenta bulge. So that's why when you scan the placenta, when you want to determine the low-lying placenta, the full bladder is very important for you to appreciate all this. The placenta bulge, the bladder wall, okay? And then you can appreciate this is a placenta, you can suspect this is a placenta accreta. And sometimes you can, if you magnify the image, you can actually appreciate this focal esophageal mass, where the placental tissue break through the uterine serosa, extending beyond it. And most of the time, from my experience, if you have this, patient will complain of hematuria, whereby they actually extending into the bladder serosa. And most of the time, patient will have hematuria. So another thing that you can suspect, this is MAP or PA placenta accreta spectrum, is your uterine vesicle hypervascularity. But the sensitivity and specificity for this is very low. So sometimes you may mistaken it's just a hypervascularity over the placenta, over the uterine wall. Okay, this is the things that sometimes you need MRI to confirm the bridging vessels. Okay, whereby the vessels extending from the placenta cross the myometrium and beyond the serosal bladder, running perpendicular to the myometrium. Okay, so bear in mind, all this is just clinical suspicion when you are doing ultrasound. The ultimate and the final diagnosis only can be made by doing when you do cesarean delivery, whereby you can have the gross specimen looking at the placenta and see how the extensive or the vessels going into either whether going into the myometrium only or whether the serosa or to the bladder. The ultimate diagnosis is only can be confirmed by doing a histopathology, where we need to see under the microscope whether this choroid villi extending towards the myometrium, endometrium, or the serosa. Okay, so moving on to another abnormality that you commonly see besides the placenta previa, which is part of your differential diagnosis of antepartum hemorrhage, which is your placental abruptio, which means basically a separation of the normal located placenta after 22 weeks of gestation and prior to the delivery of the placenta. You can have bleeding around the placenta, whether in the maternal side, which you have a placenta, which you known as a placenta abruptio, or you can actually have the bleeding around the placenta in the chorionic side, in the fetus side, meaning that you have some bleeding in the subchorion. Usually you call it subchorionic hematoma. So when you have this abruptio placenta, is an obstetric emergency, and you need to have a fast action to save both mother and the fetus. So what you can see and appreciate when you are dealing with placenta abruptio. So basically, first of all, you have to appreciate this is a normal placenta. This is the myometrium, and between the placenta and the myometrium, there's a huge gap. Okay, there's huge hypoechogenic between the placenta and the myometrium, and this is what we call a retroplacental clot. Okay, it can be black, it can be enhanced, but most of the time, because clots is already form a clot, so you will have a hypoechogenic mass between the placenta and the myometrium. This is another example whereby you can see the placenta. This is the myometrium. This is the myometrium. And this is some huge hypoechogenic mass between the placenta and the myometrium. So this is another example that you have you're suspicious of abruptio placenta. The other thing that you can have a clinical suspicion is your placenta become very thick, besides on top of your hypoechogenic mass. This is also a case of abruptio placenta. So, however, bear in mind, placenta abruptio is a clinical diagnosis. You cannot run away from your clinical manifestation of abruptio placenta, which is triads of vaginal bleeding, abdominal pain, and hypercontractility of the uterus. Okay, some other signs and symptoms: lower back pain, preterm labor, unrecognized fetal, the abnormal CTG, or patient come in the state of shock. So you have to be very careful when the patient comes with these three triads. And the other thing, you have to do the ultrasound and look hard for abruptio placenta. Some abruptio placenta, as you know, is a revealed abruptio. So sometimes you may not find any clinical findings or any ultrasound finding of the abruptio placenta, but patient may present with blood stain Liqour. So this will increase your clinical suspicion of the abruptio placenta. So when we move on from abruptio placenta, there's one more condition which we got a lot of referral for this also, what we call a subchorionic hemorrhage or subchorionic hematoma, that you commonly referred to us as a bleeding in the first trimester. Okay, and usually what we can appreciate actually a bleeding in between the chorion and the endometrium, which usually occur in the first trimester. Sometimes it may be big, sometimes it's more small, but it still depends on your clinical judgment and your clinical presentation for you have no active intervention to do and will need some admission and observe the patient. So last but not least, after we already seen what's the three placental abnormality and the cord plus abnormality that you can appreciate from the placenta evaluation, we have this. This is quite familiar to all of you, where we can see in molar pregnancy, where presence of heterogeneous mass with hypoechogenic mastocystic areas filling the entire uterine cavity. So the key is uterus larger than that. So we have 12 weeks pregnant, 12 weeks gestational pregnant a lady come and clinical examination is about 20 weeks. So you put a scan, you have this picture, your spot diagnosis will be molar pregnancy. So bear in mind, when you have a molar pregnancy, just have a look at the side, at the nasal area. You sometimes might appreciate this. The ovaries become hyperstimulated. Hyperstimulation because of the increased level of the HCG that can cause a thicker lutein cyst. nothing to worry about this Liqour leukocytosis. It will it is a self-limiting. It will sometimes it may cause pain, which require patient to be admitted. And we don't have to remove this in the acute state. We just have to observe the patient and give some pain relief to reduce the pain. And this is what we see in the gross specimen in the molar pregnancy. So again, to enforce what I've been talking for the past 30 minutes, the hallmarks of abnormal placentation or imaging, you have low-lying placenta with the inferior age less than 2 cm. You have placenta previa, which cover the internal os, or you have the placenta vasa previa, where the presence of fetal vessels in front of the internal os. So, APH, you have abruptio placenta or placenta previa. So, abruptio placenta, I already tell you 3 triads: bleeding, bleeding pervaginally, painful bleeding, and uterine hypercontractility. And for previa, painless vaginal bleeding, red bleeding, relaxed and soft uterus. E for episodes of bleeding, meaning that it's not spotting, it's basically bleeding, fresh blood. Visible bleeding. Sometimes they may triggered by the intercourse, and most of the time will associated with abnormal fetal position because of the abnormal localization of the placenta. So, shall we take a break? 5 minutes? Then I think it's too much to absorb. Chan?
Yeah, okay. Well, a short one. I think we little bit short of time today.
Sorry. Dr. Yuzi, Dr. Chan, we are already short of time, so we are finishing soon. So probably we will keep this topic of Dr. Yuzi to the next session 2 weeks later. Yeah. So those of you who are still with us, please join us 2 weeks later. Dr. Yuzi will still be with us, and she will elaborate with us about amniotic fluid assessment.
I think we can just have a few, because I have only 5 slides for this.
Okay, then we will just quickly get over with it. Go ahead.
Okay, fine. So basically, fluid assessment is just basically for technique. Okay, how you should assess the amniotic fluid correctly and reported it correctly, and you can do some readings regarding fetal condition associated with oligo and polyhydramnios. So basically, skip this. You know, the amniotic fluid increases as the gestational age increases. So this is the thing that we need to emphasize to you. The technique of measuring the amniotic fluid. Okay, so we divide this is the uterus. So we divide the uterus into 4 imaginary quadrants. You use the linear Niagara to divide into the right and left axis, and the umbilicus as dividing point to the upper and lower axis. So make sure your transducer is parallel to the maternal uterus, not the maternal abdomen, but the maternal uterus. As you glide the probe, you must make sure the probe perpendicular to the uterus, not like this. And you measure the deepest pocket, devoid the umbilical cord, you avoid the umbilical cord and also the fetal part, and you measure vertically. And in order for you to have the amniotic fluid index, you measure the 4 quadrant and sum it up. So this is the correct placement of the transducer. Make sure it's perpendicular to the uterus. This is wrong. This is not perpendicular. And this, as you can see, this you put too much pressure to the abdomen and the uterus, and you will disperse of all this Liqour volume, and you have an incorrect measurement. So this is a few incorrect caliper placement. Make sure you have a vertical between the myometrium and also the fetal part. So 2 objectives assessment, your MVP and also AFI. I'm sure all of you have done that. So this is normal value for AFI 5 to 25, MVP 2 to 8. Okay, we hardly use this, so just disregard that, and you have this amniotic chart to compare with. So these we are commonly reason why we have oligo. I'm sure you can do your readings, and your polyhydramnios. especially those with maternal diabetes, and also you have to exclude the common one such as duodenal atresia or double bubble, and also congenital diaphragmatic hernia. So just a quick assessment for twin. You do DVP, not the FI, and dichroic etiology comparable to the singletons. And why is it important? Because in monochorionic, you have these two, your TTTS and your SIUGR, where you have oligo polysequence or oligo normal sequence. So you have to identify the separating membrane and you do your measurement. Okay, this is just example of your TTTS where you have this oligo and polysequence, right? So key point, last, placenta age must be less than 2 cm for you to consider low-lying placenta, and you need to repeat back in next TCA. And all APH must exclude these three things: your placenta previa, your abruptio placenta, and your vasa previa. And all vaginal bleeding with ultrasound evidence of placenta separation is an obstetric emergency. So morbidly adherent placenta should be excluded in all cases with low-lying placenta with cesarean delivery, history of cesarean delivery. This is a normal AFI, okay, normal value. And you use MVP, not the AFI, for you to assess amniotic fluid volume in twin pregnancy. And as you know, polyhydramnios is associated with increased risk of poor outcome due to preterm labor. With that, I thank you.
Thank you very much.
Thank you so much, Dr. Yuzi.
Dr. Michael, we
lecture.
proceed with the quiz.
Yeah, so our apologies today. We have so much of content to share with you. So the time has passed us. It's 4:30. So we will Q&A your questions. We will answer them during the 2 weeks later during the bonus 2 webinar. Okay, and later during your feedback.
Recording stopped.
During the feedback also, please, if you have any other questions, just put in the feedback at the last question. Okay, I will prompt you, so we will answer them in the next webinar. So now we are going to have a quiz. So please get ready your mobile device as usual. Handphone, iPad, iPhone, up to you. And I will be running the quiz as usual. We have one winner, okay, who will get the prize. And we'll try to have a bit of music this time. So let me share my screen for the quiz today. Okay, let me share my screen. Wait a minute. Where's here? Okay, is the screen up, Dr. Chan?
Yep. Yes. All right.
So please look on your mobile device, and as usual, turn on your browser and type this website www.menti.com and key in some numbers as you see above on there's an 8-number combination 1500 and so on. Okay, so we give some time for participants to join us for the quiz.